Name of presenter, name of discussant.
I'm Dr. Lalit from Kalyani Kidney Care.
Right, Lalit.
Presenting the case.
Okay.
So Kamal from NU will discuss.
Okay.
Yeah, a 71-year-old male presented with complaint of poor stream of urine since 2 months. Please, next slide.
Can you please tell earlier there was no symptoms or?
Yeah, earlier there were no symptoms.
Suddenly he said from 2 months a poor stream is there.
Yes.
And it is gradually decreasing or it is same like what it started from 2 months?
No, it's gradually decreasing.
Okay.
Why are you asking that question?
Sir, sometimes due to the bladder stone, the stream is intermittent, or sometimes he will tell that more at night or something when he stands like that.
No. See, most of our patients may not be so insightful. Second, they'll give you some answer. These are things you have to derive as you go along. But what is definitely relevant is that it was sudden. On that you should probe in the OPD. How sudden? Did it suddenly, did it start all of a sudden in the midst of his working day or so? That has a meaning.
There is only one group of individuals I found who are very good historians as patients. Bengalis.
They tell you everything about everybody in the family.
Babu will have a full file from day one when all this started, from the day he was born right up to what the situation is. He is very good historians. History of burning, history of frequency, urethral stream, evacuation.
Patient has history of straining since 2 months and history of incomplete evacuation of urine also from last 2 months. History of interrupted stream present and history of increased frequency of urine. In daytime 6 to 7 times and at night 2 to 3 times. And there is a history of burning maturation also. And no history of fever.
Plus NT?
Sir, present, sir.
Why don't you just put a plus?
Yes, sir.
No one uses plus NT. Okay.
Okay. There is no history of fever, urgency, hematuria, leukorrhea.
What other history will you take? This has happened suddenly.
The next slide is remaining history.
Okay.
No history of any periurethral discharge.
See, that any is not required. No history of periurethral discharge.
Okay, sir. No history of trauma. No history of catheterization.
History of trauma where?
To perineal regions.
So you must mention that.
Okay.
The perineum.
No history of catheterization or any urological instrumentation.
Hey, please keep a check on your spellings. Okay. Catheterization, for example, is E after the T.
Okay.
Okay.
Yeah. Patient is known case. Oh, okay. Patient is known case of hypertension diagnosed 4 years back on medical treatment on Telma 80 mg daily. No history of diabetes mellitus, TB, no history of smoking and tobacco use.
Can telmisartan cause urinary difficulty as an adverse effect?
No, sir.
No, sir.
Who said?
Kamal, sir.
Why no? You must justify, man.
Sir, it has nothing to do with the urine output, sir.
Adverse output की बात नहीं आई यहाँ. Here we are talking about his difficulty, sudden difficulty and that and this.
Passing urine.
in passing urine. Okay, tell us what are the drugs given for hypertension which can cause difficulty in passing urine? Because these go under the radar many times.
Diuretics can sometimes cause overdistension.
What diuretics, Kamal? Think logically, please. What diuretics, even a heavy night at the bar can cause it. Go through the list of antihypertensives and see which of them have an effect on the bladder and maturation.
Okay, sir.
Okay, exercise for next time.
Yes, sir.
Okay.
These are all very common drugs, and it's important to know some of them no longer being used, but still there are patients on these older medications because they have no side effects and their hypertension is controlled with it. So nobody wants to fiddle around with it. So, yeah. Carry on.
Carry on with it.
So as per the history, sir, and the 75-year male with the history of poor flow and storage LUTS.
Okay, we have gone through the history.
Yes, sir.
What other history ought to have been taken? In a sudden onset difficulty in passing urine. He's 60 years old.
So I'll ask about pedal edema is there.
Hey, Baba, what does that have to do with difficulty in passing urine, man? In the history stage, pedal edema it doesn't come. You look for it.
Yes, sir. Sir, his maybe output is reduced and he's saying that flow is poor. What he flows before us.
Now you want a private hospital?
I'll put it this way. What conditions, non-urological, can also present with difficulty in voiding, sometimes sudden?
Constipation, sir.
Batate jao yaar. You always begin with the biggest things.
So hyponatremia.
What disease conditions or which systemic disorders? You guys can't think beyond urology.
Sir, history of stroke, sir, if patient have a stroke.
Yeah, stroke. Then
Electrolyte imbalance.
that won't be 2 months. Stroke will happen in the night. Morning, they say, is also not passing urine. But yes, stroke can. Then.
So electrolyte imbalance.
In the same area.
No urology.
In the same area. In the same area.
Yes. So Parkinson's, multiple sclerosis.
Not Parkinson's. Multiple sclerosis at 61 is rather rare. Sorry?
So multiple myeloma on chemotherapy patients.
Okay. Multiple myeloma with?
Patients on chemotherapy on multiple myeloma.
No. Multiple myeloma with presentation. अब आप कीमो में जाएंगे तो मार खाएंगे.
Vertebral fracture, sir.
Either a fracture or spinal compression.
Spinal compression.
IVDP, sir.
61 years IVDP. There is no space for the disc to come out. All the ligaments are calcified. Think, Praveen. But let Kamal answer. See, one thing I want to make clear. No answering out of turn unless we ask. Okay? When we throw it open to anybody can answer. What else a little lower down, maybe, perhaps? Any other degenerating neurological condition? Any other non-neurological conditions? We keep talking about it so many times. Boss, Kamal,
Yes, sir.
you have to return after a year if you get stuck at this stage. All of you. Okay? It can't be like this. Okay, move on. Move on.
Yes, sir.
On examination, patient is conscious, well oriented, ECOG 1, vital, BP 160 by 96, pulse rate 72 per minute, temperature normal, no pallor, icterus, cyanosis, clubbing,
What is the spelling of icterus?
ICTR.
ERUS.
Yes, sir.
It is icterus. Okay.
He always follows T, man.
Yes. Next. Local examination, prepucial skin retractable, external urethral meatus normal, both testes normal in size and shape, total skin normal, DRE anal tone normal, prostate normal in size, non-tender, perianal sensation intact, BCR present.
It's not coming.
Okay.
Next slide.
Just go back for a minute. Something missing here. What is missing, Kamal?
So rectal loading.
Rectal loading तो ठीक है, बाकी यूरोलॉजी की बात कीजिए ना. Which you would normally do when you look at the perineum. Examine the perineum.
So urethra, will palpate the urethra.
Yeah, you said something, some stone, something. You'll palpate the urethra.
Can you feel the prostatic urethral calculus on rectal exam?
Yes, sir.
You can, only if you begin to look for it. Otherwise, you can just do a cursory PR and leave it. But you must think about it, and then when you begin to think about it and do a careful rectal, in many patients you will be able to feel that stone in the prostatic urethra.
Yeah.
Carry on.
Yeah. Systemic examinations, CVS, respiratory system normal, abdomen also soft and non-tender, and spine examination is normal.
Boss, in the abdomen,
Yes, sir.
there is an enlarged spleen and there is an enlarged liver. Will there be tenderness all the time? Why are you stopping at tenderness? That means everything else has gone out of your head. There could be organs and masses palpable.
Okay.
So you okay. You have to put it there in abdominal examination. Okay. How did you examine the spine?
Any deformity in spine, sir? We'll look for that.
How did you look for the deformity?
Any scoliosis or kyphosis?
Yes, how did you look for it?
Sir, we'll ask the patient to stand and we'll look from behind and from
Okay.
left.
Okay. And then? What else?
And then after that, we can palpate, sir, for any tenderness.
You'll palpate the spine all the way down to the sacrum.
Yes, sir.
Okay. Yeah. Then next.
Can I just add a point on the sacrum? You mentioned it. It is important, especially in children. You see, when you have a child who has got voiding dysfunction, one of the things is a neurological history and a neurological examination. And sometimes when you do a plain X-ray, you miss out things like sacral agenesis, partial or complete, simply because the colon is loaded and it covers that whole area. And when you begin to examine the patient, you just turn your finger the other way. You face the volar aspect on the prostate. You turn it around the other side, and then you will be able to actually palpate the sacrum at all or not. And in many of these children who got sacral agenesis, there is no sacrum. So try to practice that. Whenever you do a rectal exam on these children and younger patients, just see if you can feel the sacrum and get into the habit of it. And then you will be able to make a diagnosis of sacral agenesis. Then you look at the X-ray and then you say, okay, that's what it is. Just an add point, Mohan was talking about sacrum. That's what I thought I'll interject at this point. Okay. Carry on.
Yes, sir.
As per the
What's your summation? Nothing on examination. 4 months history of post stream, isn't it?
yes, 2 months, sir.
Whatever. No, nothing. So what's your diagnosis?
So, my diagnosis would be benign prostate, sir, enlargement.
How big is the prostate on rectal exam? Prostate is normal in sizes.
So most common cause of poor flow in elderly, sir.
Huh?
No, Kamal, refine your reply.
It can be bladder outlet obstruction, sir.
Yeah,
It's the same, man. There is no answering out of turn. Kamal is answering it, he will answer. You refine that. You said benign prostatic enlargement.
Yeah.
Can you refine that reply?
Yes, sir. And sometimes lateral lobes are not that enlarged. Medial lobe is
Don't
enlarged.
say all that again. Just say could be median lobe. Period. Finished.
Medial lobe.
Could be a median lobe enlargement.
Yes, sir.
Then the other questions won't come.
Yes.
Okay, we'll take that onto the list. Others?
Then vesical calculus, sir.
Okay, vesical calculus.
What is the
Large or small?
Sir?
Has he got any symptom related to vesical calculus?
Only poor flow, sir, and frequency.
It's usually a painful
Yes, also.
condition.
No? They said he's got some burning and all that in the urine.
Yes, burning also.
This may be interpreted as burning, dysuria, whatever symptom you want to call it, but he's got an associated pain, isn't it?
Yes, sir.
So his urinary symptom is not generally painless. He's got a pain when he's passing urine.
Yes, sir.
He's got a poor flow.
Yes, sir.
In a patient who's got only standard BPH at this age, pain is a factor which is missing. It's very important. When you take the history from these patients, you ask them, have you got any pain? No pain. Some guys will say, yes, I've got pain. I've got some terminal pain. I've got something. So obviously, pain is a sign of some form of inflammation or infection. Something is happening there. Otherwise, they should not have pain. This is how you differentiate patients in the OPD who require some testing, who require nothing else at all. So, it's very important to note that pain is an important component in this whole history.
And more often, in bladder stone, the pain initiates the desire to void. A few seconds earlier,
Yes.
they have a pain and then they have to go to void. Stream is poor and there might be some hematuria, may not be some hematuria.
Yeah.
Which sort of bladder stone is likely to give rise to difficulty in passing urine? A big stone or a small stone?
Sir, small stone, sir.
Very nice. No?
Big stones also, sometimes they have a
Yes.
projection into the prostatic urethra. They can, but by and large, small stones more commonly. Okay?
So small stone because they are more mobile and
I
they get-
agreed. I have agreed with you. See, when a judge is agreeing with you, you should not argue with him.
Sir,
Okay.
third possibility could be stricture urethra, sir.
Okay. But you didn't palpate the urethra.
Yes, sir.
Okay.
And no history, negative history, no history of
No.
instrumentation.
What do you argue?
catheterization.
Differential diagnosis. Hey, change the slide here.
Then examination, investigation कर रहे हैं, sir.
Okay. No. Your diagnosis.
My diagnosis, sir, prostate enlargement, vesical calculus, and stricture urethra, sir.
Anything else possible? Something that precedes the stricture. Which is why perineal examination of the urethra becomes important. Urethritis might not always be accompanied by discharge.
Yes, sir.
Okay, but the fact that he doesn't have fever, he doesn't have discharge, and that he isn't complaining of something painful in the perineum, probably puts it off the list. Anything else?
Painful urination is a significant symptom in patients with urethral stricture. 20 to 25% of patients with stricture urethra will have painful urination. They call it, we used to call it dysuria, but that term is no longer used, but it's a very apt word to use actually.
The IC has abandoned it.
I know. Anyway.
Sir, I'll proceed with these three diagnoses in my mind, sir.
No other. Okay. Let's move on. We are not accepting those three, but let's move on.
Now move to the next slide.
Yes, sir. So as per the biochemical list and counts, all reports seems normal, sir.
Except, I don't know, that might be reference range.
Yes, sir.
Okay, we'll move on.
Move on, next slide.
So urine pH turbid. But
See,
pH is
look at the important positive things first.
turbid urine with, sir, WBCs in the urine.
अरे बाबा,
But
उसके बीच में कुछ नहीं है क्या?
trace of albumin, sir.
What about the pH?
Specific gravity also.
Specific gravity is normal, sir. It is in normal range. And pH is 6. 55 to 6.5 range. Leukocyturia is there along with the epithelial cells with 3 to 4 RBC, sir. And bacteria is present.
Now,
Suggestive of infection, sir.
hey, I don't expect this at an MCH level. WBCs indicate inflammation. It could be sterile inflammation, it could be infective disorders or infective pathologies. You can't assume that WBCs is infection. Okay.
Yes.
RBCs. There is something odd here. You see, they say appearance is turbid, but there's only trace albumin. Where's the turbidity coming from? Okay, these are the things you should notice.
Where's the albumin coming from? Where's the albumin coming from? Then you'll be able to answer the question of where the turbidity is. The albumin comes from the kidney, isn't it?
Yes, sir.
If the urine is turbid and there's only trace of albumin, most of the turbidity will be related to not the kidney. It must be the bladder, isn't it?
Yes,
Yes,
yes.
you've got a problem with his bladder. Is that poor stream? So turbidity would indicate what?
So stasis, urinary stasis in the bladder.
Very good. Stasis, yes. So there could be, this fellow may be having stasis, urine has become turbid. All right, he's a hypertensive, he's allowed to have at the age of 70 a trace of albumin. But the stasis would explain bacteria and 8 by 10 WBCs. So you need to find out as to why this man has got this turbid urine and possibly stasis, which might explain to you this poor sleep. Right?
Move on.
The urine culture grew Candida albicans. Then,
That also explains the turbidity.
turbidity. Pan sensitive, sir.
No pan sensitive. Sensitive to these, there are other antifungals.
So this is what usually we do sensitivity survey.
So,
It's all right.
tested antibiotics or tested antifungals.
There are still many more antifungals in the market. All of them are not being tested. So you can't really
Yes.
say.
Yes.
So what's unusual here? Are you surprised?
Yes, sir. He is non-diabetic, and so far he is not any history of any urolithiasis or any foreign body or instrumentation. His Candida is growing, sir.
Yeah, so what else, what is the other information you want to get out of this guy? Unless you ask him and dig him, he may not be able to, he may not think it is significant. He's still bothered about his burning.
Can Candida by itself cause urinary difficulty?
Sir, like pyelonephritis is caused by the fungal balls if stuck in the uterus.
Hey.
Are you going to pyelonephritis?
Where is pyelonephritis?
No, the fungal balls can cause that.
They are not in the kidney. Those fungal balls are in the bladder.
Yeah.
So can they cause obstruction?
Yeah, may cause.
May cause is neither here nor there. Tell us yes or no.
Usually Candidas are causing obstruction due to secondary some factor, maybe vesical calculus or an
But the Candida infection can also cause retention or difficulty, and the candidal balls are huge.
yes, sir.
Okay, so that's a possibility. But we would still be worried because why did it happen all of a sudden 2 months earlier? And Dr. Ganesh's question, if it is Candida balls, then how would you approach, what would you ask the patient? He may not tell you because he's more worried about peeing.
So I'll be worried about his glycemic control, sir.
Arre Baba, arre.
Not diabetic.
He's not a diabetic man.
Not a diabetic.
The Indian population might present with no.
Oh, boss. OSAP for Public Health Foundation of India. Let's talk urology. We are asking of a urological observation which might help make this diagnosis, which usually the patient will not give, but we may have to ask. Sometimes the patient, like Dr. Ganesh said, Bengalis, will tell you size, color, shape, everything.
Have you asked patients how they are given a sample of urine for culture? Ever? They'll make an honest answer to that question. Have you ever asked your patient, how did you collect this sample of urine for culture?
Usually, sir, when.
No. Have you asked this question of your patient?
Yes, sir. I have asked, sir. I have asked, sir.
You asked. Now, what will you ask this fellow?
I'll ask whether he has given midstream sample and the way he has collected into the container.
How will you ask him that? See, in our country, you have to be very specific with our patients.
Yes, sir.
Did you do this? Did you kill that fellow? Did you do this? Then only you will get the answer. See, when you have a specimen of urine for Canada,
Yes,
I
sir.
agree that you have to look for somebody who is immunocompromised. The second question you need to ask is whether this fellow has had an antibiotic course somewhere else for this problem. For he must have gone and seen some GP. You would have pumped him with 2 or 3 antibiotics.
Yes, sir.
Thirdly, when you look at the collection sample, when you look at asking him the collection, you know how patients do? They may give midstream urine, but they dip the whole john in the bottle. No, the penis is dipped into that. And these bottles may be lying around here and there, you don't know. So, this is how it is. How
Yes,
is
sir.
that bottle? Is that bottle a sterile bottle? Is it a covered bottle? Is it something there? Do you know that in certain places they give you for urine culture the old vials of penicillin and all that still on something? Can you speak into that? Yeah. So you have to be one step ahead of the system and ask as to how he gives his urine for culture.
Yes, sir.
So now what do you do now?
So I'll ask for an ultrasound abdomen with pelvis and pre-post.
Pre-post what?
Void, sir. Yeah.
Void. You don't want KUB. You don't want KUB X-ray. You can diagnose a vesicle calculus.
So much cheaper.
Yes, sir.
Huh? Show some image.
Image is not there, sir. Only report.
Right.
The bilateral small non-obstructive renal calculus, sir, with both kidneys normal shape and ecotexture. Bladder wall thickness appears normal with a PVR of 110. Prostate 16.9 grams.
Yes.
Pre-void we don't know, sir. Pre-void.
Now, what other question of relevance in today's context will you ask this patient? Knowing all this, knowing this ultrasound, knowing this history, knowing this urine culture report, what other question of relevance will you ask this patient? Trying to find out how the hell he got this cavity.
Sir, I'll ask, did he completely empty the bladder the way he does at home?
He does that. He says, I did that only. I did whatever you asked me to do, I followed. I'm giving you a hint, man. In the context of today's climate, today's scenario, will you ask him anything more? We may not be able to tell. He won't tell you. One, because he's scared. Two, because he didn't think it's relevant. Because he has recovered from it. But that could have impacted this urine culture. Yeah. No, yeah. But man, Kamal,
Yes, sir.
what is the disease which is raging in the world?
Sir, COVID, sir.
Yes. You know what treatments are given for COVID?
Sir, telemedicines, telephone, they are doing all the things.
Yeah. Everything.
Yes.
Polypharmacy.
Any medicine available
The
which
antibiotic.
ends with win or veer is given.
Everything is pumped in, man. Huh?
Yes, sir.
So it is your business in today's world to ask this question. And many patients may not divulge this because they are scared. Because if you ask them, I had COVID, they'll really chase you off from the hospital.
Yes.
COVID is a bigger stigma right now than HIV.
But it could be HIV also that you should be looking for.
Yes.
I mean, in the
No,
background.
don't. Yeah, 70 years old is not a contraindication for any of these things.
Have I told you this story about hints?
About?
Hints. Giving clues and hints.
Oh, right. No.
No. We had a gynec prof, Krishna Kumari, you might know her.
Of course.
Okay.
Oh, yes.
So, her hints would be like this. Usually about true labor, false labor, and so on. And her hints would be, a question would be something like, what happens at 16 weeks? So the fellow is suddenly caught unawares. She'd say, what, boy? You don't play football? That fellow gets even more confused.
Confused.
And then, what do you play then? Huh? You play volleyball? You play that? You play this? He's thoroughly shattered by that time. And her clue was kicking, the fetal kicking in the uterus. You had to pick up from that. Onset of true labor, he would ask, boy, which movie show do you go to? Morning, matinee, evening, night? I know you have a girlfriend. Don't hide it from me, it's all right. This fellow is wondering what show, what movie, which. It would begin with which movie did you see last? The clue was supposed to be show. Very funny lady. And
Was Professor Balakrishnan there when you were there?
he had left.
Huh?
I joined after him.
Oh, yes, right.
I joined after. I missed him from what I hear.
Yeah, I know. Yeah.
Yeah, okay, Baba, now what do you do?
What do you do now?
First is, why is he having this difficulty in avoiding when the stones are in the kidney?
Have you made a diagnosis yet? You said median lobe, no? Kamal,
No, cycle calculus, no, sir, median lobe.
you also discussed median lobe, no? Is it
Yes,
there?
sir. No, sir.
Then you see whatever diagnosis you thought about.
Yes, sir.
You said median lobe because the prostate was normal and it still has features of post-stream. There's no median lobe enlargement, or if it's there, it's not being mentioned. It means that obviously it's not significant.
Yes, sir.
Huh.
So, X-ray KUB was not done, sir. Uroflowmetry was done.
Uroflowmetry was done. Okay. Right.
Is suggestive of, sir, poor flow and plateau curve, sir.
Some of us, I think, must shed this reluctance to do an X-ray KUB where required. If we suspect a stone, it's good to begin with X-ray KUB.
Yes, sir. Yes, sir.
Most people will do NCCT. No?
Yeah. No, but even that is okay. Compared to ultrasound and other things which can't image the lower tract. Okay. What can you make out from this?
Suspicion of stricture urethra, sir.
No. You can't make that out.
No, but
What is the pattern of flow? In a uroflowmetry, you are expected to comment on the pattern of the curve.
So, plateau curve is there, persistently
plateau.
poor flow.
No, it's
Persistently
a
poor
plateau.
flow.
It's a plateau curve, which means flow is poor, and there are no increments in flow.
Yes.
Okay, from beginning till end, the flow is poor. Period.
Poor.
Yeah.
Steady poor stream.
Yes, steady poor stream.
Hey Lalit,
Yes, sir.
is this a Dantec machine?
Sir, I don't know, sir, which type of machine is that, sir.
Well, what nonsense, man. First run you would have made to the urodynamic lab to see what all machines and equipment you got. Go look up
Okay.
radiology, urodynamics, ultrasound. See what machines you have, what their capabilities are.
Okay.
Whether it's only a Uroflow meter or whether you have a combined urodynamic suite. Okay. I'm taking a guess that this is Dantec. Okay.
Sir,
Okay.
What do you do now?
I will start the patient on antifungal and ask for an RGU MCU, sir.
Why RGU MCU?
Why not do cystoscopy?
I would not like to do a diagnostic cystoscopy, sir.
No.
First, I have
Why
a
diagnostic? No, it will be
You
there.
can do whatever you want.
Why do you want to RGMCU? He's got a poor flow. You have treated him for his Candida. He's got a high PVR. Nothing in the upper tracts. Full stop. Do a scopy. Why do you want RGMCU and then produce a extravasation, sepsis? Do a scopy.
The scopy itself is an invasive, sir.
It's invasive to proceed.
RGU MCU is also invasive.
Sir, I wanted to plan my procedure.
You can still plan it. You can still plan it. Scopy. Boss.
Yes, sir. If it is stricture, I would like to do a buccal mucosa graft, so I have to.
Okay, hey. Don't run.
You are very,
If there is a
very
reason,
keen to wield the knife, huh?
if there is a reason for doing an RGU MCU, it is that if there is a stricture, you may not know the proximal extent and presence of other strictures proximal to where you have stopped. So to visualize the entire urethra, you might do an RGU. MCU may not even be required. Okay, Kamal.
Yes, sir.
That should be your justification. And why don't you want to do it after the cystoscopy? Sir, it is possible during cystoscopy if some injury occurs, that will give a false impression or something else in the urethrogram. And patient may not agree for double procedures.
Another situation could result if you did not evaluate the patient and proceeded to cystoscopy, that you may be surprised that there may be a stricture there, and then you create a false passage and land up doing an SPC for this patient, because you may never be able to find the urethra in that situation sometimes. So, it's a good practice to know what you're dealing with. So you have an RGU which will tell you whether there's one stricture, two strictures, multiple strictures, where is the extent. So you'll outline the penile and bulbar urethra. If they are normal, then you are okay. You are home and dry.
Done?
Yes, sir. RGMC is done.
Yes,
Sir,
sir.
is done?
RGU, well done.
Arey Bapa.
This is plain X-ray, then RGU, sir.
No, you tell me what is the most significant finding in the plain X-ray? Significant urological finding and significant other finding.
Jansen's MRI. What the hell is that?
Dr. Prabhakar, good morning.
Dr. Prabhakar is not here sir, today.
Not there,
He
he's
will
not.
not come today? Okay. I
Sir,
thought I
actually,
heard
our
his voice.
X-ray machine was not working at that time. That's why we
No,
sent
no, no.
outside.
This is okay, but there are some findings. We will see why these findings have come. If you were given an X-ray from the best X-ray machine, then what would you say?
When you are reading a plain X-ray radiograph, you first are told that you have to look at the position of the patient and the position of the X-ray. Is that okay and symmetrical? Then you look at the exposure, isn't it? That's what we are taught. You look at the exposure. Is the exposure, is it overexposed or is it underexposed? Then you look at the plain X-ray is basically done to look for the bones and anything else in urology. And look at the bone structure. And then look and see whether the bones have the normal density of calcium. Have they got very less? Is there significant osteopenia? Is there significant osteoporosis? Whatever. And then look at other abnormalities because this fellow is 71 years old. Look at age-related degenerative changes in the bone.
See, if I'm presented with this X-ray, I'd be seriously worried because the cortex is all right. There is no medulla and the cancellous bone seems to be depleted in the pelvis, in the femur, everywhere. Okay, so I would really worry whether it is something like multiple myeloma or sarcoidosis or he's got something else. So that's the point I was drawing. It doesn't matter, we don't make this diagnosis on X-rays alone, and KUB X-rays usually come out well. How do you make out whether it's underexposed or overexposed, Kamal?
Overexposed.
That's one simple question.
So overexposed and bony markings are prominent, sir?
No. When do you know? This X-ray, see, bony markings depend on the bone. How do you know it's appearing like this because of underexposure or because of overexposure?
So I'll read this, sir. X-ray KUB overexposure, sir.
Why do you think so? I'm asking you why. How do you read as overexposure? Somebody brings you a film. In orthopedics and thoracic surgery, that's very important for them. And often for us also. How does one recognize whether the exposure of a film is appropriate, overexposure, or underexposure?
Sir, I'll read this, sir.
Right, okay.
No, you won't read it. What will you look for before reading? Reading begins after you're satisfied about the exposure. Hey, it's getting late, guys. Come on, quickly.
9:20 years.
Dr. Prabhu, or not Dr. Prabhu. Has Dr. Manish come?
Yes, sir.
मनीष साहब थोड़ा इनको ये चीजें दिखाइए शायद इन्होंने देखी नहीं होगी.
Okay.
How to recognize over under simple things. A few other things also I've told them earlier. Okay.
Yes.
Right. Let's move on.
Charging.
So this is an oblique view of a handheld retrograde ureterogram.
Handheld retrograde ureterogram.
Handheld
What is
technique
that, Baba?
It's a handheld technique used for
They
now.
don't use, see, Kamal, in
Yes.
the exam, don't use unnecessary terms to show off what you know. Just say this is a retrograde urethrogram. What have they used? They use the syringe injector. Period.
Yes, sir.
Okay. Somebody will then, sit around, laugh at you and ask, please show me how you do foot tilt. Okay.
In this, sir, penile urethra seems normal. There is a distal bulbar stricture.
Exposure में कोई दिक्कत है? Positioning में कोई दिक्कत है?
Yes, sir. Position is not adequate. In a
What do you mean? No, you have to say what is wrong.
Yes, sir. Both internal, this obturator foramen are seen, sir. In adequate exposure, one foramen.
No. Not adequate. Proper exposure.
The proper
What
exposure.
is the next? Which
Second,
is
sir,
unsatisfactory.
The right legs are supposed to be more.
No, not legs, man. About the urethrogram. Papa, कहाँ भाग जाते हैं?
I mean, the urethra should be parallel to the femur bone, sir.
What does that mean? Parallel to the
No overlap. No overlap.
See, there is no stretching. We had this problem last time also. We don't know where the bulb begins and ends. We are seeing something, we think it's the bulb. We don't know. Okay, then what else?
The plain film was taken, which shows there is no foreign body.
What is that bubble in the middle? Plain film पे क्यों जाते हैं आप? यहाँ आ गए ना?
Yes.
What is that bubble in the middle? You have to mention that.
Yes, sir.
There is a globular radiolucent appearing mass or lesion seen in the line of the urethra around the prostatic urethra.
Viru montanum, sir.
We know, why should it be globular like this? Viru, you'll find this stream splitting. So the Viru is somewhere here. It's much higher. Yeah. Okay.
Then it could be air bubble, sir, then.
Whatever, something there. Okay. What about the bladder?
The contrast
is entering the
and
bladder.
entering the bladder.
Okay, fine. Next. What do you see?
Penile urethra appears normal and distended.
No, it is not normal. That's why you have to stretch the urethra well.
Yeah.
Where is the pinobulbar junction?
So at the level of pinoscrotal junction.
इसमें दिखाइए ना.
इसमें सर ये pinoscrotal junction है.
कैसे मालूम? इतना short penile urethra. जहाँ दिख गया वहाँ दिखा दिए. अगर वो पिनोस्क्रोटल जंक्शन है तो बाकी ये सब क्या है? Come on, no.
Rest is the bulbar urethra, sir.
No, man. Where have you seen such a long bulbar urethra?
Mohan, I'm just going into the OR.
Okay, thanks. Sorry, we couldn't conclude it. Do you want this carried forward?
No. I'm just going to see her.
We can do it. Yeah. Okay. Thank you. Yeah.
So, penile urethra seems normal, small because
there is a peaking there. Following that, there is a narrowing, okay, which is almost completely obscured. Following that, next, more proximally.
Yes,
yeah. And then you go up along the same line.
Even the bulbar
Follow the bulbar urethra.
The
Follow the
bulbar urethra
bulbar.
is
Yeah, there. Stop.
not fully distended, sir.
Wait. I am telling you now, don't interrupt me. You see,
Yes, sir.
this place again is narrowed. Correct?
Yes, sir.
Here, bulbar urethra.
Bulbar.
Forward, man, proximal.
This one, sir?
Yeah, okay. Then move up further, just below the air bubble or whatever. It is narrowed again there.
So
You
this
don't
is the
have to
corner.
make a diagnosis. You
This is
just
corner
have
of
to
the-
say there is narrowing. There are a lot of findings in this. We can take a full class. But that, and then you say that verumontanum in contrast is entering the bladder. We can't make out about the glandular urethra because the syringe is there. Get it?
Yes, sir.
Yeah, move on. I've given you the findings. Move on.
That's it, sir.
Where is the MCU?
MCU not done, sir.
Why not done? Lalit?
Sir, only RGU was done, sir.
No. Unless you do an MCU, your strictures will not be defined properly. Some of these narrowing areas here might actually distend well on an MCU. The narrowing might be only because there is a proximal distal stricture which is slowing down the flow. Okay.
Okay, sir.
We won't discuss management. Right, Manish?
Yes, sir.
कहीं और चला जाएगा. Okay, maybe you can sit and discuss with Dr. Manish. If you want another session for management, we'll have a session for management with 2 or 3 similar strictures in the urethra.
Okay, sir.
Okay. Yeah. Thank you, folks.
Thank you.
Thank you.
We'll close now and see you all next week. Have a nice weekend. Ganesh Chaturthi, Gauri Vratam today. And Manish, you didn't go to Leh.
I went, sir.
Brave man. Okay, right.
Thank
Good.